Anything.
Good evening. Thanks for joining us tonight. We've got a number of people kind of joining us here, and we'll just allow a moment for folks to enter in. Let's see. Thanks for joining us. We'll get started in just a moment. Well, as folks are joining us, we will go ahead and get started. Thanks for joining us tonight. My name is Jenny Kemper, and I'm the director at Kemper Cognitive Wellness, and Dr. Nate Bergman is here with me and will join us shortly. We've got many familiar names joining us tonight, and we're happy you could carve out a little time in your schedules to join us. I do want to note that it's rather stormy in Cleveland, and we've already lost power where I'm at once today. So I'm hoping we don't have any technical difficulties as we proceed. If we do, though, rest assured we will reschedule right away and get you this important information. Thank you for joining us tonight to learn more about the newest, the first drug that the FDA has approved in 18 years to treat Alzheimer's disease. This is an exciting time indeed. Dr. Bergman has a lot of good stuff to share with you. We welcome your questions. And I just really quickly wanted to kind of remind you how to navigate in Zoom if you're not familiar or what have you, to interact with us and ask questions. If you scroll with your mouse to the top or bottom of your screen, you should have a bar, a Zoom bar, and there's a chat feature as well as a Q&A feature. You can use either of those to interact with us. If you'd like to ask your question verbally, you can also raise your hand and I can unmute you and you can do that as well. Let's see, I think that's all I have in terms of housekeeping, and we'll go ahead and welcome Dr. Bergman now.
All right, hey, thanks, Jane.
Yeah.
So, yeah, I know that when I register for webinars all the time, and most of the time I just want to get the recording so I can watch it. So, we had obviously a lot of people that registered. I imagine some of you guys will be listening to this in recording. So I have, this is an evolving time. I mean, we're going to do our best to keep you updated on what's happening with new medications. This is daily news now almost. We're living in a day and age, as we all know, for the last year and a half or so, where we really have to learn to study studies, right? We have to learn to sort of sort through the evidence for ourselves and rely on people that know how to read evidence to sort of do the heavy lifting when we don't have time or don't feel like we have the capacity to do these kinds of analyses for ourselves. But obviously, it's not medical advice. Please consult your doctor for what's right for you. And if I'm your doctor, I guess we'll get rolling. Okay. I have 4 basic goals for tonight. 4 basic goals for tonight, and I'll be sort of checking the chat intermittently. The most important goal is really that we clarify our current understanding of this new medication, Aducanumab, Aduhelm. That's, of course, the reason that we invited everybody tonight. Secondarily, I think it's also important to revisit our understanding of Alzheimer's disease, of what it means to prevent, what's early intervention, and how this new drug fits in to that understanding. And then third, I want to know what you guys think and feel about the new drug. And so feel free to ask sort of like, personal questions around yourself or, someone you care deeply about, or that you just, any questions. Like, the main thing is that you get something out of this. And then, like, the last piece, which I'll hopefully cover towards the end here of our hour, is understand what else is going on in the Alzheimer's space that may be appropriately paired with a medication like this. But again, I think the main thing is just that I want you to get something out of this. So if you have a question, don't wait till the end. Don't wait, like some of us were trained to wait till the end. There's no one that is really an expert at this medication yet. And I've talked to a couple of experts, so-called, experts that know, I've never prescribed it. Really no doctor in the community outside the context of a study is prescribing it yet. But I'll do my best to field questions. If we don't have the answers, I'd like to think that we can chase down the answer for you. So please send them in as you have them. That's the most important things, that you get your questions answered here. And so that we have a couple of basic survey questions, Jenny. Can you launch the first survey question? You'll see a survey sort of appear. So the question really is, what is your working understanding of this new medicine, right? I'm sure if you're here, you've read multiple articles, at least one, you've seen it on the news, talked about, but is this is something that's clearly helping, and this is sort of the beginning of a cure. Maybe the drug shouldn't have been approved by the FDA. Maybe you're not sure. You want more information. You've read some stuff. You've heard some stuff, or if you just you have no idea. Right? If you can click it. Do we have anybody that's voted, Jenny? Do you know?
Oh yeah, we have half of our folks have voted, and I will note that it's anonymous, so nobody will know how. We'll share the results here in just a moment.
Just click the box and
yeah. So we've got about 90% in. So
okay. Maybe we'll just
last
keep rolling
chance.
Down. 5, 4, 3, 2, 1. All right. Let's see what the results say. Okay, I'm not certain. I want more information. Because that sounds about right. So most people, about half, just more than half people are not certain, want more information. And then another, like a third saying the drug should not have been approved by the FDA, which, there's definitely a strong camp that supports that. And then, one person was honest and said, I don't know, I have no idea. That's why I'm here. Okay, good. Yeah, so that's about what we thought, I thought most people would either say, I'm not sure, or probably it's not a good idea, right? So Jenny mentioned before, 18 years since the last drug was approved. As you know, probably the FDA earlier this month on June, it was huge news, on June 1st, the FDA gave something called an accelerated approval to Biogen's medication. So forgive me if this is, if some of you guys are deep in the weeds in this and it seems overly basic. I don't want to sort of assume that people know anything. So we're gonna kind of get at this bit by bit. So if it seems like review, and if I get anything wrong, or if my understanding is different than yours, let us know. Please let me know. So what is an accelerated approval? So they give it to Aducanumab, which the brand name for this is Aduhelm. Biogen's in Cambridge, Massachusetts, with their Japanese partner Eisai, developing this medication. Right, so the FDA's accelerated approval pathway is really provisional, right? So it's an approval contingent upon the fact that more clinical trials or more evidence will arise that verify a clinical benefit, right? And there's like a 9-year window for Aducanumab to do that. So this is not something that's immediate, but this is, the FDA does this from time to time for life-threatening diseases that really don't have a lot of other medications in the space. Usually it's no other medications. And it's important to remember that the FDA could revoke this approval if they decide they want to do that. I have a couple of graphics that I'm going to share. The first one, again, I want to make sure we're all on the same page about what Alzheimer's disease is, right? So it's really important. Can you see the slide, Jenny? Can you see the slides?
Yep, thank you.
So it's important to remember that, it's just to sort of make a distinction. It used to not be important. And when I say used to, like 3 years ago, 5 years ago, it wasn't maybe important, it didn't matter to make a distinction between Alzheimer's and dementia, right? Because usually think someone with Alzheimer's is someone who is bound for Kemper House, who needs an assisted living, who can't take care of themselves. That's dementia, right? So that's dementia, and Alzheimer's is a kind of dementia. But Alzheimer's doesn't start as a dementia. And that's really an important thing to get out of this, right? So dementia is defined as an inability of someone to think or to have the memory that they need, the brain function they need to kind of get through their day, right? That's dementia. And then, there are a lot of different kinds of dementia, right? Alzheimer's, we think, is probably the most common in this country, but there's a bunch of different kinds, and we can get into that. It's sort of a different talk, a different time. But Alzheimer's disease is not necessarily the same thing. I actually want to launch the second survey question, if we could, Jenny, before we go further, and then we'll be done with our survey questions, and we'll just stay informational after that. Be able to launch the next survey. There we go. Okay. Yeah. So here's the question: when does Alzheimer's disease start? Right? When someone has dementia, when someone starts to become a little forgetful, or they're not as efficient at work, or like 10 to 20 years before someone gets dementia, or maybe you have no idea. And I don't want to spend too much time waiting.
Yep.
I'll let you count
We've
down.
got everybody in, and we've got a pretty sharp group here, Dr. Bergman. Let's see.
The 10 to 20 years. Okay, so these are people that are informed, right? So not sure 10 to 20 years before someone gets dementia, when someone starts to become forgetful. Okay, so right, so that's it. I mean, you kind of nailed it here. So this is I think this is a really important slide, if you will. Jenny, you see that? You can see it, slide I'm showing.
Yep.
Right, so this is, as you move to the right on this slide, we're all getting older, right? And so, part of aging, just like our skin changes and our joints change, so does our brain to some degree. It's just hard to learn new information as fast as we once did. Perhaps certain kinds of recall for certain words. We have so much in our minds, so much in our brains. Maybe it's hard to reach for certain words. That starts to happen for some people in the 30s, 40s, 50s, often 50s, 60s, 70s, that'll start to happen, right? It's the sort of typical, and that's some cognitive aging is normal. The broken line here, though, is the Alzheimer's trajectory, and this is from an international working group, mostly from the National Institute on Aging. So these are our government's conceptualization of how brain function or cognitive function is lost over time. So on this graph, higher is better, lower is worse, obviously. So nowadays, right, in today's day, and leading up to 2021, most people are not paying attention to this until they get into the so-called mild cognitive impairment stages, or full-blown Alzheimer's dementia. But make no mistake about it, Alzheimer's actually is starting up here. How long is that? 10, 20, 30 years, 5 years? Does it move more quickly in some people than others? Yes. But approximately somewhere between 5 and 30 years, on average, probably 10 and 20 years, before people have symptoms like a lot of breakthrough memory symptoms. Now, the big distinction and some of the semantics that people get confused on in this conversation is that you don't have to test abnormal on a memory test to have the beginnings of Alzheimer's disease, right? Like, you could still be testing normal because the tests aren't that sensitive. And so that's part of what our field's doing, is trying to make the tests better and more sensitive. But it's really important to recognize that mild cognitive impairment, or Alzheimer's dementia, right, which is mild cognitive impairment here, and then the beginning of early Alzheimer's dementia all the way through sort of later stages where someone may pass of this, are fairly far along, right? If you've heard me talk about this, like cancer, right? So just like cancer, we move through cancer, stage 1, stage 2, 3, 4. We have less people dying of cancer now, even though we still have a lot of cancer, because of being able to pick it up early, being able to detect certain kinds of cancer early: colon cancer, breast cancer, prostate cancer, lung cancers. Now we're screening for certain other kinds of genetic cancers we can screen for, right? So that's why it's important to have more information, right? But I think the critical piece here is to know this is fairly advanced. Most of the clinical trials, most of the drug trials, and all the studies are starting with an assumption that Alzheimer's disease starts here And that's where a lot of the belief is that a lot of the treatment failures have been failures. A lot of the drug trials have been failures because of how late in the game or late in the disease process we are beginning treatment. So the field has recognized, oh, hey, we need to start picking people up early. So you may have gotten emails about a prevention trial, which is mostly just getting imaging, like getting to know whether or not you have markers that are like Alzheimer's. And then this particular study that we're talking about today, Aducanumab, as you guys probably know, really focused on the group here, mild cognitive impairment and very early Alzheimer's disease. So Alzheimer's dementia, right? So dementia by definition, having trouble living independently, can't maybe drive as well, or I'm getting a little lost, or missing a bill, or having some trouble with technology, right? But that's already a fairly late stage. So it's really important to sort of like clarify that, because when we talk about treatments, like the treatments are most difficult and have the least effectiveness so far the later we wait. So this red box is where aducanumab has been studied, but at least they moved the needle up into the mild cognitive impairment, and then you're going to probably see in the future trials people with milder and milder symptoms being you could say being experimented on, but using these the experimental medicines in drug trials to see if we can ameliorate symptoms sooner, right? So kind of with that in mind, I want to turn back to the medication. Now we kind of understand where in the disease process started most likely many years before the folks in this study were included. I think the longest person that's been on the drug I saw was 7 years. She's been in multiple clinical trials. Her and her husband are fairly influential in the Alzheimer's disease research, Us Against Alzheimer's Foundation. But the first and most basic question is, does aducanumab work? Right? And so the effectiveness question is the key question, and that is the question around which a lot of the controversy started, right? So 2 big trials. In order for FDA typically to approve a medication, you need a new drug, you need 2 phase 3 clinical trials. So aducanumab was not born yesterday. This has been in trials since at least 2011, and they go through a pipeline. First phase 1, you have to take basically healthy people and see if at different doses if there's any safety problems, meaning anybody has major side effects. Then phase 2, you start to take, usually take 100, 250 people, 300 people, somewhere between usually 150, 300 people approximately. And you start to talk about, well, does it help symptoms? Is it effective in terms of does it make people any better? And at what doses? And is it still safe when we start to test more people? Once there is proof of concept in a phase 2 clinical trial, we move to phase 3. And those are bigger. Those are usually what we call multi-center trials. If they're sponsored by a drug company, cost a lot of money to do, a lot of money, and tens of millions of dollars typically. And so this had 2 of these large clinical trials, about 1,650 people in each trial. They're very, very similar. All of the inclusion, the people they included and excluded were basically exactly the same. And these 2 trials were called Emerge and Engage. Right? And the Emerge trial ended up showing a small improvement, right? A small improvement, meaning that the decline in people was less severe for the 18 months that they were using the medication versus the people in the placebo group, the people that didn't get the medication. Problem was the Engage trial didn't show any improvement. And when I say improvement, I mean they drew a line. So any study basically, just because it costs money to maintain and go on, and usually they fold these trials really fast if they're not working. This particular trial drew a line in the sand and said, if this doesn't slow things down by 20% more than placebo, we're gonna trash it. They call that the line of futility, the futility point. One trial failed completely. The second trial passed that futility point by 3%, 3 percentage points, so 23%, right? So that's the problem here, right? So the conclusion, therefore, is it's not clear if aducanumab will improve Alzheimer's symptoms. So meaning what symptoms are we talking about? Memory, language, ability to say, sort of cognitively intact enough to maintain independence, right? Now, what is clear, and what was sort of the reason for the FDA's approval, what is clear is that aducanumab, like many drugs before it in the similar family of immunotherapies, it really does seem to remove the toxic amyloid protein bundles that are found in Alzheimer's disease, right? The problem is previous studies also saw removal of these plaques, but it didn't prevent people from getting worse. It also, sometimes the drugs themselves actually made symptoms worse, right? I thought it was telling. I found an article from Babak Tusi. Maybe some of you guys know Dr. Tusi. Dr. Tusi's at the Cleveland Clinic. He's sort of their lead clinical trialist for drugs. So he's works at Louisville, with like Parkinson's and Alzheimer's specialist. And he was quoted in Alzheimer's News Today just a few days ago. And he said, a lot of people ask me, did memory improve for your patients who got aducanumab? And he said, no, this medication does not turn back time. What you can expect is that maybe 1 year from now, you can call your doctor and say your memory hasn't changed much. That's as good as you can expect. Now, I know Dr. Tusi a little bit, and he's a funny guy. He's got a sense of humor, and so, but he was being quoted in a publication, so I'm sure he was pretty precise in his language, right? And so, just to sort of this seems to be something that people are a little less familiar with, which was what was the tool that was used to assess improvement or less decline, right? It's a tool that was just called the Clinical Dementia Rating Scale, sum of boxes, CDR is what we call it. It's used by geriatricians in nursing homes sometimes. It's definitely used in clinical trials. Basically, the best score is a 0. It's like 0 is you have no problem, and then the higher the score gets, up to 5, the more independence people lost, right? So the score looks at things like memory and orientation and judgment and problem solving and how people are doing in their life in their community, how they're doing at home, and with things they enjoy, hobbies, etc. And then just basic things like personal care. Can someone brush their teeth? Can they shower on their own? If you put food in front of them, could they eat? So the key though here is that, and I talked to the director of translational research at Cleveland Clinic about this, and he's been a part of many of these trials. He told me that to fill out the CDR takes him about 15 to 20 minutes. So that was the big metric. So something it takes about, it wasn't like a scan, it wasn't a blood test, it was someone's opinion after talking for about 15, 20 minutes with someone who was diagnosed, right, with either mild cognitive impairment or early Alzheimer's disease, right? The reason they chose this tool is there was a lot of hubbub about 8, 9 years ago to see if we could pick things up earlier, right? And this tool was thought to be better represent a spectrum of disease, right? That more severe cases were obvious, but the more subtle cognitive impairment was thought to be picked up by this tool. I would argue that this tool is probably not as sensitive as it needed to be. But anyways, that was the tool that CDR sum of boxes. So it just rates how quickly decline. The best score you can have is 0. So you can't get better than 0, right? So then so 23% less worse was what the aducanumab did over a year and a half of getting it, right? We can quickly move through how it works. Aducanumab is what's called a monoclonal antibody or immunotherapy. Immunotherapies are available in other disease states, cancer, autoimmune diseases. And like we mentioned before, it pulls out these toxic clumps of amyloid, which is thought to be a main feature, although arguably it's a main feature of Alzheimer's disease. It's given IV once a month. So you have to go in for an infusion. The infusion will be done at a hospital or an infusion center. It takes about an hour start to finish from what we understand. The dosing is based on a person's weight and like the first 6 months, you're ramping up a dose, right, until you get to the magic dose of 10 milligrams per kilogram of body weight. So, like you figure out your body weight in kilograms, let's say 70, and you're getting a 70 milligram dose. That's only after ramping it up slowly. So there's a dosing protocol if you look on the label that Biogen put out for aducanumab. Again, clinicians are not ready to be prescribing this. People are learning now. They're sort of scrambling to learn. We'll talk about that in a little bit. But that high dose was the dose where Biogen was able to conclude that people taking it might be improving, right? Another question that came in from people on our own team at Kemper Cognitive Wellness, and then we had it from a few other people, is how does it compare to other existing drugs for Alzheimer's? The previous drugs that were approved by the FDA, mostly Aricept, which generic is donepezil, and then rivastigmine. There's some patches that are basically the same thing. And the other one, Namenda, which was the more recent one that was approved, or memantine is the generic. Those really don't have an impact on the disease itself. The term you might be seeing is DMARD, or disease modifying agent. So those are thought to really deal with the main problem. Aricept, Namenda, the previously approved medications, they don't deal with the underlying problem. Here with aducanumab, it really does target what we think is the problem, the cancer, if you will, the problem, although that's still arguable, right? That's still arguable. So a lot of unknowns, but it is fundamentally different than any other medication because it may be, aducanumab, Aduhelm, may be modifying Alzheimer's disease itself rather than trying to deal with some of the downstream consequences that like the other medications did. So key question it was very clearly part of the 350-page report that the FDA's Independent Advisory Council included, as well as Biogen's own report that we went through from this drug. And it looks like, in terms of safety and side effects and monitoring, which are big questions, and some of these are unanswered questions, but about 41% of people getting aducanumab had some kind of side effect. So I have another little slide to show you while we talk about this. The main side effect was something called ARIA, right, which stands for amyloid-related imaging abnormalities. You guys hopefully can see that, Jenny. Amyloid-related imaging abnormalities. And there are a couple different kinds, right? We used to, in the literature, if you look back in the literature from the last several years as these things were being studied, you'll see things like vasogenic edema and microscopic hemorrhages, but there are basically two broad categories of these side effects. And these are important because especially if you are planning on, on considering this. Kim, I see your question. We're going to come to that for sure. Are there any other, the question, just somebody sent in a question saying, are there any other treatments that decrease amyloid plaques? So we'll get to that. There are, and there's more coming. There are two basics. So one is the ARIA-E, which stands for edema. So that's swelling. And you can see, this is an MRI picture of the brain, sort of a top-down view on the brain. Same thing here. These are called coronal images, whatever. And so these are, so the white parts is that swelling. So what that means is that this is a vasogenic edema, or ARIA-E, is a kind of brain swelling where, like, the edges of the blood-brain barrier, which is a barrier that sort of keeps our brain safe and somewhat protected from other things through really tight connections. Those tight connections loosen up and start to leak a little bit. They break down and it allows fluid where it shouldn't be. And so that's multiple versions, in different kinds of ARIA-E. This was in a publication from a few years ago. This is this is becoming more characterized. So this is something that, again, as these medications start to be prescribed more and more, there's no doubt we'll start to see more side effects, and this will have to be managed. The other form, which was a little more concerning to me, although this one's still concerning, the E is concerning, but the other one is the H, is hemorrhage, right? So two kinds of hemorrhages are bleeding, right? The big bleeding, macroscopic, and then the microscopic brain bleeds. The microscopic brain bleeds are something that concern me over time. Like this study was only 18 months. I think this will become a bigger deal over time. But right now, all we have is 18 months of data. The other thing that you can find in this is sort of microscopic, macroscopic in this sort of H variety is deposition of or iron deposits, harmful iron deposits in the brain. Those were less common. And I should point out that the micro hemorrhages were 10 times more common than the large hemorrhages. So there really weren't that many. What I read in the report, in the FDA report, was most people about 47% of people developed headaches on this medicine. Another about 15% developed confusion or delirium. 11% dizziness, 9% nausea, another 5% had fatigue and blurred vision. There were some, you'll always, in a study like this, you'll always have like seizures, larger hemorrhages, but those were like very, very small numbers, right? And then there was a few other side effects, falls and diarrhea and some other things, but the main side effect to be picked up was this area, this amyloid-related imaging abnormality. And so I think it's important to, to be fair, because it's very easy to sort of just take the sort of pessimistic view on this. And I'm sort of in the middle. And I'll give you my straight opinion in the end here. But the area-related, these side effects that you see, they're really showed up in the first several months, 8 months, as people ramped up to that higher dose. The study reported, and this is it's also important to remember that these studies, if you look at who they included and who they excluded a lot of people that we see in real life, people that were had cancer, people that had heart disease, people that had open heart surgery, people that have diabetes, like so complicated people that often get Alzheimer's disease, right? So usually what will happen is in a relatively healthy group of people, the side effects aren't as bad, and then you start to get more people using a medication, you start to notice more side effects. And those are often not listed because they don't show up until we start many more people. And then, like we don't know what to attribute to what, and we blame heart disease on it. We don't always blame the medications. But at least in this study, the study reported about 80% of people that developed, so 4 to 5 people that developed the images I just showed you, the MRI stuff, the area side effects, were able to be managed by adjusting a dose, and within about 4 months of getting those side effects, the side effects had pretty much resolved, right? Another important piece of information that didn't get press right away, but it started, but we were, like I know myself and my colleagues were kind of talking about this, and it seems to have gotten a little more press in the last couple of weeks, but an MRI really has to be done after this, the 7th treatment. So this is monthly IVs. You go into the hospital or an infusion center, is very similar like cancer. You go into an infusion center after the 7th and 12th doses, and you need to so monthly, sorry, but after the 7th and 12th dose, you'd need to get an MRI, right? It could be as people are on this medicine or these kinds of medicines longer and longer, there would be a need for more MRIs. Right now, it's not clear that insurers are going to pay for those, right? It's not clear at all. One other thing that's relevant to our group here, I know it's particularly relevant to a couple of people that were signed up for this, so I'm going to mention, and you probably already know this if this is you, the Biogen data, so the data that they published about Aducanumab, does suggest that these kinds of side effects, the MRI abnormalities, the ARIA side effects, are more common and fairly significantly more common in people with an ApoE4 gene. And so there's people thinking about why that is. We could speculate, but I think it's really beyond the scope of this. I want to take a breath, but and allow for some questions if people have them. But the other question is people are asking is, well, how long will I need to take Aducanumab? And the answer is we don't know, right? We just have no idea. The study was 18 months long, and even the drug label itself, when you look at Aducanumab's drug label, like there they talk about, they say the data is too limited. The data are too limited to make definitive conclusions about long-term safety or effectiveness. So we don't know, right? Let's take a pause there. Like we've been talking a lot. I just want to see if there are any questions. If anybody does want to sort of, okay, when the dose was adjusted to decrease the side effects, was the dose then below the therapy? So that's a good question. So Kim asked, right? When the dose was adjusted to decrease the side effects, was it then below the therapeutic dose? Right. So not clear. Yeah, the answer is most likely yes. I can't say for sure, But yes, because the doses, the side effects usually showed up in the first 4 to 6 months for people, and that was still being ramped up to 10. So the idea was they slowed down the dose and then sort of would increase it as tolerated. And then so some of these people ended up getting more MRIs, more frequent MRIs, because they needed to for the safety of the study. And then your question, though, is a good one, like, meaning if the conclusion on the aducanumab data of the two so-called successful trials was that they had to be on a high dose, and that was the whole reason, which we can get into a little bit if we need to. The whole reason that they reopened this trial was because they did a reanalysis of the data, and it was only the high doses that worked. There's a question whether those people that had the side effects then were able to be ramped up to an effective dose. So I think the answer on the dosing is, like, this has been my experience with cancer and the times that we spent in the ICU or on oncology wards. Like, you'll have the doses are starting guidelines, and then doctors, physicians, clinical teams will work through, okay, is this dose effective for this person? Do we need a lower dose, a higher dose? So again, the answer is we don't know, but that's a very astute question. I had the same question myself. So I don't know, Jenny, and I'm not sure if you guys want to get into the whole controversy back in 2019. People have probably read about it, but it is worth it. Just so, again, I want this group to be comfortable understanding how the sausage is made, so to speak, because we're going to soon have 2 more drugs like this, really soon, probably coming down the pipeline, and they've already gotten sort of a tacit approval and are sort of applying for like a higher level of approval for this same kind of in the aducanumab family of drugs. But I don't know if
you're referring to the
donanemab and lecanemab.
Yeah. The conclusion that the one trial was ineffective, and then
what happened was
why don't you speak to that?
In March, I remember this because I just started at Kemper Cognitive Wellness with Kemper, and it was, I've been following this for years now, and like the big question was aducanumab. That was like the Biogen stock was up, then it was down, then it was up and down, and in the March of 2019, they announced we're just gonna kill the aducanumab trial. It was a failure, didn't pass that futility marker. But then, curiously, and this was also big news, in the fall of 2019, after reanalyzing data that became available to Biogen later, they just made an announcement, sort of a pronouncement, that it was they were going to again seek FDA approval. Right, so this was fall of 2019. This was really big news in the Alzheimer's community, and the company basically cited the data that the eMERGE trial had more people that they were able to sort of include later on at the higher dose, and they concluded that the reason that the eMERGE trial was successful, meaning they passed that line of futility, and it was at 23%, just slowed down Alzheimer's just a little bit more than the placebo, was because this group was exposed to the higher dose for a longer period of time. Al Sandrock, the Biogen chief medical officer, put out the statement. He was like widely criticized for it. But that was Biogen's angle, right? That was Biogen's angle. As you guys know, there was like really a split in the Alzheimer's community, in the Alzheimer's advocacy community. Alzheimer's Association was definitely pro aducanumab theoretically. They had, you probably know that they've taken about $1.4 million from Biogen for whatever reason. That's not uncommon across the board in organized medicine. There were people writing in to the FDA in January, public letters in journals saying we need a win. Alzheimer's community needs a win. Us Against Alzheimer's, which is another sort of pro Alzheimer's medication and research organization. They were sort of putting pressure on FDA, saying the patients need this, patients need a win, we need something. So the FDA was under a lot of pressure, and not that should make them determine what they do, but As you guys know, after the FDA announced this accelerated approval, within 4 days, 3 of the 11-member independent advisory council, so people that didn't work for the FDA but were advising them, resigned, right? And so that was like, again, I assume you guys know all this, but there was a professor of Harvard, one of the first guys to bail out, Aaron Kesselheim. It was probably the worst drug approval decision in recent US history. Washington Post quoted a couple of the other resignees talking about this is a terrible precedent for lowering the bar for drug approval, FDA. Another one was quoted in the Washington Post. David Knopman, who's a Mayo Clinic neurologist, said he didn't want to be part of a sham process. And what I thought was more interesting wasn't just the headline of the sham process and this, like, because you can make your own decisions. But what I thought was interesting, and this you had to have some inside information for, was he said that there was a bunch of statisticians, right? So Biogen presents all their data, and then you have to have smart people that know how to tear up data and make comments on it, sort of have at it. You have to give them adequate time and adequate access. And access is always a big question with these trials, but then enough time. And so there's one statistician apparently had a dissenting opinion, and he and this Knopman, this Mayo Clinic physician who was part of this 11-member committee, who also ended up resigning, he said that this FDA statistician who had written the data on the drug was conflicting, wasn't permitted to present a full airing of his analysis. So those kinds of things are disturbing, and I think that's probably what's given rise to the news this week that the House is going to investigate. And I think, I'm sorry, I'm getting a text from Jenny. All right, so I think other news here is that, and I think it's worth saying, that 2 more drugs that have been, again, Aducanumab didn't come out of nowhere, neither did the next Biogen medication, BAN 2401, which a lot of the research, the patient advocate organizations called Lecanemab, also called BAN 2401, if you've heard of it in that way, also is a sort of in the process of receiving breakthrough therapy designation. So there's a breakthrough therapy drug designation in the FDA, which requires even less evidence. You don't need the phase 3 clinical trials to get sort of experimental approval. There's another medication which some people view as a good thing and sort of competition for Biogen from Eli Lilly, which you may have heard of. It's called donanemab. All this, they sort of work in a similar way. They're all designed to take amyloid out of the brain, right? So I think, like, if you wanted to spend some time on cost, we could spend some time on cost, $56,000, which is $4,300. That's just for the price of the drugs. What a lot of people are not aware of, it didn't seem like, that we were talking to, was that just that price, that was the wholesale cost. That's not necessarily what you'll get it for. And then that doesn't include imaging, consults, IV therapies. There were some really nice analysis done by a few different people, but particularly there was a nice article in the Atlantic by 2 law professors that essentially did their analysis show that if 1/3 of the estimated 6 million people with Alzheimer's in the United States received the treatment, the healthcare spending would end up being $112 billion annually, right? For this, and we're spending like $90 billion right now for like 46 million Americans with Medicare. There's Medicaid is an issue. Medicaid is partly state funded, so states will have to decide, Aducanumab for people or something else, school budgets, you name it, right? So it's really creating some downstream pressure. The other thing that they pointed out, if you don't have secondary insurance, you just have Medicare Part B, since it's going to be in a doctor's office or hospital, Medicare patients will be on the hook for about 20% of this. That's like $11,000 a year for this medication. And, if it worked, it would be one thing. But if, now it's like, does it even work, right? Even the CEO of the America's, if you've heard of AHIP, it's health insurance industry's main lobbying group, they were asked what would be an acceptable price, and he cited an often quoted, and maybe you've seen the report from the Institute for Clinical and Economic Review. So this is a think tank that focuses on like value and costs of healthcare. They thought a fair price for what aducanumab is doing would be somewhere between $2,500 and $8,300 a year, right? And that's $56,000 just for the med. So like now there's a whole congressional investigations. We'll see, we'll kind of see, right? Questions about when it will be available. The drug was supposed to be available at the end of June. I talked to somebody at Luruvo, and they said, we're just like not ready. We have to train doctors, we have to train staff, we have a place to do it. We need to make sure people are getting like the scans or the lumbar punctures that they need so that we know that they have amyloid, right? The FDA did not put any limitation on who could get it. So theoretically, if you had enough money, you could take someone from Kemper House who is sort of like could be on hospice theoretically, and say, hey, we'd like to see if aducanumab works. And if insurance covered it, they would theoretically need to cover that, if there's no sort of restrictions. So there's a lot of unknown. So that's sort of the cynical side. I just want to spend the last few minutes here talking about reasons for optimism, right? I think if nothing else, what this drug is doing is it's sort of again raising an awareness about us needing to know for ourselves what's our individual risk, right? And then also understanding that the sooner we either know our risk because it runs in our family, we're starting to have real mild symptoms, that's the time to do something. If you go back to those graphics that I showed you earlier, right? It's just not acceptable anymore to like ignore symptoms until we have to like take the keys away from mom, dad, husband, wife, whoever it's going to be. It's just that's not, Alzheimer's starts way before dementia, right? I think it's interesting, there's some people making the analogy of aducanumab and Alzheimer's medications to HIV medicines or even heart medicines to some degree, diabetes, and certainly cancer, where it's going to be a combination. Marwan Sabag he's the director of the Cleveland Clinic's Luruvo Center for Brain Health, so their main Alzheimer's outfit. And he said, we always have to have a first medication. It might be a third, a fourth. We'd love to combine medicines, but there needs to be a first. So my guess is, based on talking to some people that have really been in this deeply for a while, some personal conversations, is that, so this is not gonna, aducanumab is not going to change the game for anybody. It may slow things down for the right person with mild enough symptoms, but we're going to have other medicines after this. And just like statins, some of the original statin medications, some of the original chemotherapy medicines, even the original HIV medicines aren't really used anymore. Too many bad side effects. And then in the industry, the pharmaceutical industry sort of improved, made them more effective, and with, theoretically, in some cases, less side effects, right? So I want to show you another piece of good news that's, and I hope this group has heard of it, but in case you didn't, I'm going to share it with you. These are preprint. Can you see this, Jenny? I want to share with you the results of the trial. You can.
It was up a moment ago, but.
Okay. So this is a preprint. So since COVID, like if you have you can print through a publishing house in, one is with Yale and there's another one somewhere else. It's called medRxiv. And this is essentially the same approach we're taking at Kemper Cognitive Wellness. This is a precision medicine approach to Alzheimer's disease. This was only with 25 people. I just talked to somebody on Sunday in San Diego who's running a similar trial with 25 people on her own. And there were 3 different doctors in this. Dale Bredesen is the final author on this. And this took 25 people, very, very similar. So mild cognitive impairment and then early Alzheimer's disease or early stages of dementia. And I think here is sort of the easiest way to show you. 25 people did this sort of very rigorous program. 21 out of 25 people had some kind of improvement. Like, I'm just going to pause on that. 84% of people improved, not doing less worse. They improved against their scores themselves. So it was rigorous, right? There's a question of, how can people do this? Is it too much? But it was an amazing kind of improvement. We've seen this with people. We've seen this with people. Not everybody can do all the work. Not everybody's going to do all the stuff. But like, it's an amazing time to be in this field for all of us. It's there's more and more hope. There's more and more that you can do. Even one of the people that wrote the strong letters of support for Aducanumab back in January. If you go back to some of what he was, some of the videos that he and quotes that he and articles that he was written about a year ago, just a year before that, saying lifestyle and some of the other approaches are far outperforming medications, right? My hope is that we can get sort of the combination, right? I don't see why it has to be one or the other. It makes no sense to me why we should sort of philosophically, it should only, like, we don't say that in heart disease. They still do say it in cancer. We don't say that in heart disease anymore. Heart disease, obviously you want to get with lifestyle. Plus, if you need open heart surgery, you need a stent, yeah, get a stent. But you don't want, ideally we don't want it to get to that point. So kind of in summary, if you're interested in this medication, you definitely need to see a neurologist that does Alzheimer's for a living. You can just go to any neurologist. Both Dr. Lerner's group, as well as the Cleveland Clinic Blue Roof Center for Brain Health, are places that theoretically, if you can get someone to call you back, those will offer this. You definitely want to confirm that you have amyloid, right? Like that there is like that they're solving the problem that this drug, that you have the problem that this drug sort of solves, right? And that can be done either through what's called a PET scan, which is a brain scan that insurance typically so far doesn't pay for, or like a lumbar puncture, which is a spinal tap, and they can look at the protein signature and see if it sort of confirms that you have this buildup. And then you would just need the MRIs, and you sort of move from there. I'm super interested in any patients that are interested in this, sort of like cautiously getting more information, seeing if they're a candidate. I'm very happy to sort of work with you and advocate if you're interested in trying the medication, because I think this is a direction that is going to be helpful for our people and the people that we're serving with Alzheimer's. And I do think that there'll be better medication. So if you're sort of chomping at the bit to try it, I don't know that it's a terrible idea to try it, especially if you're doing the other things that we're recommending. In fact, I think you'll probably have better results, because what we're trying to understand, what we are involved in at a research level, is why do people have the amyloid to begin with? Why is there a toxic buildup? And so there's some theories around that, and those theories are sort of over time being tested. And if we can get rid of these toxic proteins, but then or more importantly, slow down or eliminate the reasons that the toxic proteins are building up, that to me would be a very synergistic approach. So I think if you're more of a sort of a wait and see person, I would wait a year and see what happens with these other two medications, see what happens with the prices, and because I think the price probably will fall. I think there's going to be some government pressure on Biogen, although we'll see, who knows. Maybe that's just all for show. We'll find out. But donanemab and lecanemab that are coming out may actually be more effective than the aducanumab shows to be. So we'll find out. We'll continue to stay on this for you. And in the meantime, I'm so happy to answer questions if anybody has them. And I appreciate your time and attention.
Yeah, so I think it's important, thank you, Dr. Bergman, to note that, wait and see is great for the drug, and see what happens with aducanumab. And I don't know if I say that as well as you, Aduhelm. But don't wait and see if you're experiencing any sort of cognitive symptoms, cognitive loss. Subjective cognitive impairment is when you yourself are noticing changes in your brain and your cognitive function and your thinking. I think most of our friends on this webinar tonight are well aware of this, but don't wait. Dr. Bergman shared that slide at the beginning of the trajectory of brain changes in adults as they're aging, and we know that changes are happening in your brain as many as 30 years before you actually start to experience those initial signs and symptoms of cognitive impairment. So every day every day matters. So don't wait. Kemper Cognitive Wellness is here to help you with an assessment. We do not diagnose Alzheimer's dementia. We refer you to a neurologist for that, but we can delve deep into what could be driving your symptoms. We use a functional medicine and precision medicine approach to get at the root causes, and it's not one size fits all here. So we look at what's happening uniquely with you and write a prescription, pun intended, of some interventions that will work specifically for you.
Yeah, and we have a lot of people that are improving. I mean, we have people that can do the work and do what we're asked to do. It's not easy, as those of you that are on the call that are that are our patients. And I try to do this work myself. It's not easy. It's not easy, but like, I recently had a woman in my office that was in her mid 80s, and she has some cognitive impairment, and she's been kind of following with us for 7-8 months since COVID times, and she said, well, I'm not really feeling better. And we kind of went through the list of the things that we had asked. She seemed to be surprised that she wasn't feeling better, and she had done like one of the 6 or 8 things that we'd asked her to do, and I guess I wasn't surprised that she wasn't feeling better, because I feel like we just sort of continue to do the same things that we did, got us here, and we're aging. It's hard. So we recognize that it's hard, which is why we've really tried to design a program. With sort of Betty and Kristen Kemper had this sort of notion that we need to do something early, and like it's not like a pipe dream. This is here now, where people are all over the country and now all over the world are improving. And it requires a little bit. It requires some effort and some dedication, but we're here to help. And like, we really, like, this is what we've given our life to. Saying we really want to help you. Spread the word.
So we're just, we're coming up on 8 o'clock. If you have any questions, now is your chance. Of course, you're welcome to email us as well at info@kemperwellness.com. If you're new to our practice, you can learn more about us at kemperwellness.com. You can find us on social media, of course. And what else do we need to share, Dr. Bergman?
Just if anyone wants to type any questions, it looks like,
Thank you for sharing that. I'm going to type in our phone number as well here. We have an 800 number. You can reach us at 855-337-1400. And you're welcome to call for a complimentary consult. So we're here to help, and love to help you on your journey. So thank you all for joining us. We will share a recording of this presentation with you. I would say in the next 24 hours, we'll get that out to you. So thanks again. And this is your last call for questions. So you were very thorough, Dr. Bergman.
Yeah, I mean, the answer to most of the questions, we're not sure yet. That's really going to be the answer to a lot of these questions. But if you are interested in trying the medication, I would just contact me privately. If you're a patient, just send it through the portal. And I'll try to, because I really do. I've had a couple of people that seem like they could get access to it, and I want to make sure you see the right neurologist that knows what they're doing, get the appropriate workup. You just need to do this the right way.
All right. With that, we'll bid you good night, and we'll be in touch soon. Have a great evening, everyone. Thank you.
Thanks, Jenny.